Welcome to the Healthcare and the ADA Inclusion of Persons with Disabilities webinar series. I'm Lewis Krause from the Pacific ADA Center, your moderator for this series. This series of webinars is brought to you by the Pacific ADA Center on behalf of the ADA National Network. The ADA National Network is made up of 10 regional centers that are federally funded to provide training, technical assistance, and other information as needed on the Americans with Disabilities Act. You can reach your regional ADA center by dialing 1-800-949-4232. Real-time captioning is provided for this webinar. The caption screen can be accessed by choosing the CC icon in the Meeting Control toolbar at the bottom of the screen. To toggle the Meeting Control toolbar permanently on, press your Alt key once and then press it again a second time. As always in our session, only the speakers will have audio. The audio for today's webinar is being broadcast through your computer. Make sure your speakers are turned on or your headphones are plugged in. You can adjust the sound by navigating to the audio settings on the bottom of the panel. You can adjust the sound by sliding the soundbar left or right in the audio tab. If you do not have sound capabilities on your computer or prefer to listen by phone, you can dial 1-669-900-9128 and use the webinar ID 760-897-977. Also, I want to note that this webinar is being recorded and will be able to be accessed on the ADA Presentations website next week in the archive section of the healthcare area. This webinar series is intended to share issues and promising practices in healthcare accessibility for people with disabilities. The series topics cover physical accessibility, effective communication, and reasonable modification of policy issues under the Americans with Disabilities Act of 1990, the ADA. The upcoming sessions are available at adapresentations.org under the Schedule tab in the Healthcare section. These monthly webinars occur on the fourth Thursday of the month at 2:30 Eastern, 1:30 Central, 12:30 Mountain, and 11:30 a.m. Pacific Time. By being here, you are on the list to receive notices for future webinars in this series. Those notices go out 2 weeks before the next webinar and open that webinar to registration. You can follow along on the webinar platform with the slides. If you are not using the webinar platform, you can download a copy of today's PowerPoint presentation at the healthcare schedule page at adapresentations.org. At the conclusion of today's presentation, there will be an opportunity for everyone to ask questions. You may submit your questions using the chat area within the webinar platform. The speakers and I will address them at the end of this session, so feel free to submit them as they come to your mind during the presentation. To submit your questions, type and submit them in the chat area text box, or press Alt-H and enter the text in the chat area. If you're listening by phone and not logged into the webinar, you can ask your questions by emailing them to adaTech@adapacific.org. That's ADATECH@adapacific.org. If you experience any technical difficulties during the webinar, you can send a private chat message to the host by typing in the chat window. Type your comment in the text box and enter. Or again, if you're using keyboards, use Alt-H to access the chat box and then put in your issue. You can also email any issues to adatech@adapacific.org, or you can call us at 510-285-5600. Today's ADA National Network Learning Session is titled Effective Communication in Healthcare. This webinar will review the Americans with Disabilities Act and other laws that apply to healthcare with a focus on the rights and responsibilities for effective communication for people with hearing, vision, and cognitive disabilities in healthcare settings. Discussion topics will include common auxiliary aids, services, and strategies to ensure effective communication, as well as ADA and local resources for training and technical assistance support. Today's speaker is Michael Richardson. Michael is the director of the Northwest ADA Center and is responsible for coordinating the activities of the Technical Assistance Unit. He provides technical assistance training, continuing education, and consultation services related to the Americans with Disabilities Act and other federal and state disability laws. So Michael, I will now turn it over to you.
Thank you, Louis. I just want to do a quick check and make sure that you are able to hear me now.
Yes, we hear you just fine.
Perfect, perfect. Okay. Let me just adjust my slides here. We'll go ahead and move to that first slide, Louis, if you can give me control.
Okay.
Perfect, there we go. First of all, thank you all, and thank you, Louis, for the introduction, and thank you for having me here today. And I do want to thank the Pacific ADA Center for hosting me and the partnership we have as part of the ADA National Network's efforts to promote accessible healthcare. Just FYI, I'm a person who is deaf and uses a cochlear implant. I have many friends in the disability and deaf communities, and unfortunately, I've seen and heard firsthand too many stories of patients and consumers with disabilities experiencing communication barriers in healthcare settings, including myself. So this is an important and personal mission of mine as we address effective communication in healthcare. Just trying to click this second slide here. There we go. So today's agenda, we'll talk about relevant federal disability discrimination laws. We'll also talk about the ADA requirements for effective communication. We'll sort of touch base on various disability categories, such as those with vision loss, who are blind, and how effective communication impacts them. We'll talk briefly about cognitive disabilities and effective communication. And there will be sort of a heavier emphasis on deaf and hearing loss and access to effective communication, because that is one of the sort of the biggest areas we see in our work here at the ADA Center, as far as which individual groups of people with disabilities often do not get provided access when it comes to communication in healthcare. And towards the end, we'll talk about good ways and ideas and guidance in establishing an effective communication office policy to address the provision of auxiliary aids and services and all that. Next slide. So there's several federal disability discrimination laws, and we'll start with Title II of the Americans with Disabilities Act. Applies to all public, state, and local healthcare providers. So quite often you'll see this apply to university-based hospitals at public universities. Title III of the ADA applies to all private healthcare providers. Next slide, please. There's also Section 504 of the Rehabilitation Act of 1973, and this applies to federal healthcare services and facilities and healthcare providers who are also recipients of federal financial assistance or federal funds, such as Medicaid funds. And then, of course, we have Section 1557 of the Affordable Care Act, which applies to pretty much all healthcare providers. And then don't forget, we have titles of the Civil Rights Act of 1964, and this federal law mandates that appropriate language access in the healthcare setting to individuals who have limited English proficiency. So this would also apply to individuals who are deaf and use American Sign Language as their primary language. And we'll talk more about that as we get into the presentation. And then don't forget, you may have state and local laws that often mirror the above federal laws that we just talked about. So always be aware of what your state laws may entitle. And remember that if state laws provide broader and greater protections, then that's the law that applies compared to the ADA. So don't always assume the ADA is a federal law that trumps all state and local laws. Next slide. Slide 12. Just a quick note on the Barrier-Free Healthcare Initiative. This is sort of, in my opinion, a really cool effort by the U.S. Attorney's offices across the nation, and they're partnering with the Civil Rights Division of the Department of Justice to target enforcement efforts on accessible healthcare. And this initiative will make sure that people with disabilities, especially those who are deaf or hard of hearing, have access to medical information provided to them in a manner that is understandable to them as well. And so the Barrier-Free Healthcare Initiative is a multi-phase plan that will also involve other key issues for people with disabilities, including ensuring physical access to medical buildings. Currently on their homepage, there's a list of various DOJ, Department of Justice settlement agreements that go back a few years. There's a small number that applies to discrimination based on HIV/AIDS status, and the rest, quite a large majority, have to do with discrimination of people who are deaf or hard of hearing in accessing healthcare services, primarily in areas where the provision of an American Sign Language interpreter was not followed through or provided. Next slide. So just kind of stepping back and going to Title III of the ADA, which is for the private sector of healthcare. Title III of the ADA prohibits discrimination against individuals with disabilities by places of public accommodation. And private healthcare providers are considered places of public accommodation. Next slide. So examples of such healthcare providers could include, of course, hospitals, nursing homes, psychiatric and psychological services, offices of private physicians, dentists, HMOs, and health clinics, to name a few. Next slide, please. One thing that's important to note is that under Title III for healthcare providers, no matter how small they are, the Title III applies to them regardless, and regardless of the size and the number of the employees they have. And the reason I want to emphasize this is because quite often we get calls from small clinics and doctor's offices asking if they had an obligation to provide a sign language interpreter because they had less than 15 employees. Now, for those of you who may know about Title I of the ADA, that applies to employment and the provision of reasonable accommodations, which applies to employers of 15 or more employees. But when we talk about services provided under Title II and Title III, it doesn't matter how many employees there are in an entity. The point is to provide access to the people who are accessing the goods and services. Next slide, please. And what's also important to note for healthcare providers under Title III, private sector, is that if a professional office of a doctor, a dentist, or even a psychologist, for example, is located in a private home, the portion of the home used for public purposes, including the entrance, is considered a place of public accommodation. So this is something that people need to think about if they're operating a private business out of their home that is related to healthcare. So what this says in a nutshell is that pretty much everything from the point of an accessible parking space to the path of travel, to the front entrance, to the area used by the services, including the restrooms and possibly the waiting area, should be accessible. Next slide, please. So now we get to sort of the core of why we're here today, to talk about sort of a core tenet of the Americans with Disabilities Act. And the key word is effective communication. And what the ADA says in simply is that disabilities that affect hearing, seeing, speaking, reading, writing, or understanding may use different ways to communicate. So we need to think about what potential barriers are out there for people who have disabilities in which communication is impacted. And what the ADA mandates is that information must be as clear and understandable to people with disabilities as it is for people who do not have disabilities. Next slide, please. So for effective communication, healthcare providers have a duty to provide appropriate auxiliary aids and services when necessary to ensure that communication with people with disabilities is as effective as communication with others. So key terms being there, auxiliary aids and services. Next slide, please. So the question is, who does effective communication apply to? I mean, often we think about, obviously, it applies to the individual with a disability receiving the services of a healthcare provider. So it applies to customers, clients, and other individuals with disabilities who are seeking or receiving the services of the center, the medical center. And what's important to remember is it may not always be patients of the healthcare provider. Auxiliary aids and services may need to be provided to spouses, partners, and family members. In other words, people who have an important right to be involved in the provision of those healthcare services. So some examples could include a deaf parent of a child patient, meaning that deaf parent would have access to a sign language interpreter, for example. Maybe some hospitals offer Lamaze classes. And so partner participation is often important in that. So if there is an expectant mother, her partner, spouse, or important family member who is involved in that birth process may also require auxiliary aids and services to participate in that Lamaze classes. Also think about peripheral interviews with family members in psychotherapy situations, for example. Next slide. So this is sort of some important information to know about when thinking about effective communication. The means used to provide effective communication is determined on a case-by-case basis, usually based on the person's needs and situation. Auxiliary aids and services are devices or services that enable effective communication for people with disabilities. And basically, in a nutshell, you consult with the individual to determine what communication method or technology will be effective for him or her. Now, Title II entities, which are sort of the public sector, often are required to give primary consideration to the request of the individual. And so if an individual requests a sign language interpreter at a university hospital, for example, then you can pretty much guarantee you probably need to provide that American Sign Language interpreter. Same with, very similar to Title III entities, which are encouraged to consult with a person with a disability to discuss what aid or service is appropriate given the circumstances. The goal is to provide an aid or service that will be effective given the nature of what is being communicated and the person's method of communicating. So generally, the requirement to provide an auxiliary aid or service is triggered when a person with a disability requests it. Now, the healthcare provider, especially in Title III, has the final say in which aid or service will be appropriate as long as the result is effective communication for the individual, given the nature and context of the information being conveyed. And we'll talk about some of those examples in a second. Next slide, please. So we'll start with the individuals with low vision or maybe blind or on that spectrum of visual impairments. People with visual impairments often receive important healthcare related information in standard print, which could be problematic and troublesome for individuals who can't read a standard print. Next slide. Here's a common scenario and an actual scenario that did happen. In this case, a woman with low vision reported that she learned only after years of taking her thyroid medication at dinner time that taking the medication with food weakened the drug's effects, which may have compromised her treatment. Now, in this situation, it was understood that a woman was given verbal and print instructions in standard print. and it's likely she forgot the gist of the verbal instructions, but did not have an accessible document in a large print to refer back to, and therefore was confused about how she was supposed to take her medications. Next slide, please. It's still addressing people with a low vision or who may be blind. Here are examples of communication needs that are often important and need to be considered as far as providing alternative formats to print or ways of communicating. So think about medical exams, tests and lab results, information explaining diagnoses or treatment, prescription medication instructions like I just mentioned, explanations of informed consent or end-of-life policies and procedures, physical therapy instructions and instructions for the management of chronic conditions, and of course, childbirth preparation resources, prenatal care materials, just to name a few. Next slide, please. So when working with those with vision loss, where information is provided in written form, especially some of the more complex stuff, ensure that effective communication for people who cannot read the text. So consider the context of the information, how critical, how lengthy, how important it is. Now, sometimes something brief and very simple may be able to be given verbally as opposed to having it printed out, but also consider the importance of the information, the safety involved around that, the length and complexity of the materials, and be prepared to provide alternative formats to print. Next slide. So some examples of auxiliary aids and services for communication include Braille, larger print text, electronic formats, and audio recordings. If little time to have anything produced in an alternative format, you may want to consider reading the information aloud. So going back to that first bullet point, it's not expected that every healthcare clinic and facility has everything backed up in Braille and ready to hand over. But for example, if something needs to be conveyed without the opportunity to provide Braille, think about providing a qualified reader. Now, under the 2008 Amendments Act to the ADA, they added the definition of a qualified reader, which is somebody who's defined as a person who's able to read effectively, accurately, and impartially using any necessary specialized vocabulary. So this doesn't mean a person requires specialized training to perform this, but healthcare providers should think about having somebody designated on staff or just having the general staff be aware that at times they may be called to work or provide services as what we call a qualified reader. And this basically is just reading out information to help somebody understand. There was a case I knew about a while back in which a friend of mine actually, she was blind, and she just told me she'd been turned away from her healthcare provider because she could not read the consent forms that she needed to sign and read upon her arrival for appointment. And the response she got from the front desk person was, "We cannot read this, we cannot help you. So please come back when you can with somebody who can help you do this," which was, discrimination right there. So a healthcare provider cannot require somebody who's blind, for example, to bring someone in with them to facilitate communication. They've got to be prepared to read some information for them, or at least maybe postponing an appointment to get somebody who is available during busy times, for example, to sit down with that individual and read some forms to them. Next slide. The same thing, at the same time though, when doing this, think about confidentiality issues. So for individuals who are blind, often report feeling frustrated and embarrassed after being forced to reveal confidential information, whether it's financial or personal, out loud in public. So think about the lobby areas or how many other patients may be waiting for services and whether or not it's appropriate to read and convey information to that individual. It may require stepping inside to a vacant office or some other part of the facility where confidentiality can be guaranteed. Next slide, please. Next we kind of move to the group of individuals who may have intellectual or cognitive disabilities. And so basically just a brief definition, intellectual disability is a disability sort of characterized by significant limitations, both in intellectual functioning, such as reasoning, learning, problem solving, and in adaptive behavior, which usually covers a range of everyday social and practical skills and often originates before the age of 18, often congenital in nature. And cognitive impairments are not caused by any one disease or condition. For example, Alzheimer's disease and other dementias, and traumatic brain injuries, and other conditions such as stroke can cause cognitive limitations. So when dealing with people who may have some different ways of communicating due to cognitive and intellectual disabilities, some just sort of guidelines include allowing plenty of time to teach a new task, using repetition with precise language and simple wording, treating adults as adults and children as children. That means including talking directly to the patient and not their personal care attendant or family member who may be in attendance. Do not pretend to understand if you do not. Next slide. Think about also asking additional questions to clarify any information the patient may be sharing with you. Maybe it's a need to reduce distractions within the examination area. Using pictures or objects to convey meaning if appropriate. There are some great new sort of handy tools out there available that provide diagrams, pain scale levels of images and graphics that are easier to understand for some people with intellectual and cognitive disabilities. Think about allowing a wait time for the patient to process information or respond to a question or make a comment. So one thing that's important to note here in these situations is making sure you're taking that extra time for the patient appointment to allow for effective communication. So this may include modifying any policies or procedures in which an office may have. For example, say a doctor has a policy of limiting his visits to 15 minutes per patient. Now, if somebody takes longer to communicate in that 15 minutes, then that healthcare provider should consider modifying that policy to allow that appointment to go over time and allow for full and equal and effective communication. And they cannot charge for that extra time as well. So other tips may include always respecting autonomy and privacy of individuals in this category. Again, using plain language when possible, and even providing questions in advance of their appointment might be helpful to facilitate communication. Next slide. And just a brief slide on individuals who may have speech-related disabilities. Some things to think about as far as allowing them to use and have auxiliary aids and services. This could include speech synthesizers, communication boards, and believe it or not, there are some individuals who use sign language to express communication, and it may require bringing in a sign language interpreter to orally transliterate what that person is signing. Maybe even thinking about giving access to a laptop, a keyboard for type communication using tablets or iPads. One thing I want to point out here is speech synthesizers and communication boards are often personal items that individuals bring with them to appointments or to engage with in the community. And the reason I want to mention these is to allow individuals to use these devices to the maximum extent feasible during the course of the healthcare appointment. And every time I do this training, I bring up a personal story of having something similar in this situation happen to me. Years ago, at the time I was wearing 2 hearing aids and did not know a whole lot of sign language. And so I relied on my hearing aids as well as my eyeglasses to effectively communicate with healthcare providers. I was going in for a minor surgical procedure, and the policy at the time was to leave all personal items in the recovery room. And so I did that without thinking, left my hearing aids and eyeglasses behind, and they wheeled me to a surgical unit about, literally, it felt like a half a mile down a large hospital corridor. And when they placed me in front of the doors to the operating room, I was immediately surrounded by anesthesiologists, the surgical team, and nurses, and what have you. And they started talking to me about what was going to happen during the surgery and post-recovery and whatnot. Now, without my glasses, I could not take any visual cues through lip reading. And without my hearing aids, I couldn't hear anything. So it was personally a frightening experience to be in this healthcare situation and not understanding what was happening because I did not have what I needed to effectively communicate. Next slide. So now we shift into sort of the bigger area that's an area we often see that needs more addressing when it comes to effective healthcare, effective communication in healthcare. And this all surrounds individuals with hearing loss and those who are deaf or hard of hearing. And one thing I do want to point out before we go further is always remember that we do have an aging baby boomer population, and many older individuals are aging into disability and aging into hearing loss. So never discount the the older population who may require effective communication, auxiliary aids and services to allow for clear and equal communication. So for individuals with hearing loss who are maybe deaf, some common auxiliary aids and services include a qualified American Sign Language interpreters. Note takers, for example, might be something to consider for Lamaze classes, for example. Written materials, assistive listening systems or devices such as FM systems or pocket talkers. Closed caption decoders, or making sure that any video and media materials is either open or closed caption. Ensuring there's possibly access to a relay service, the use of video phones, and ensuring that staff know how to answer and respond to a relay call from a deaf individual, for example. Communication access real-time translation, CART for short, which is captioning, and we'll talk more about that shortly. And the exchange of written notes may be okay in some situations. We'll talk more about that as well. One thing I do want to make clear here is that sometimes there's stereotypes or even myths out there about people who are amazing superhuman lip readers. And what I want to mention is that lip reading or speech reading is frequently, in reality, ineffective. And many factors reduce lip reading abilities such as lighting, facial hair, foreign or regional accents. And many sounds cannot easily be read on the lips. Additionally, patients who are anxious, scared, fatigued, affected by medication may all hinder the patient's ability to effectively lip read or speech read. And many deaf individuals, particularly in medical settings, will pretend to understand and nod their heads in agreement. And I tend to see this in our older population who are sometimes often in denial about their hearing loss. So the point being is lip reading is not always effective. Think about ways to ensure there are alternative ways to provide information and asking sort of open-ended questions to ensure that individuals have understood what information you may have provided. And do not assume that note writing back and forth on paper is an effective communication tool. With American Sign Language, American Sign Language is not based on written or spoken English. The syntax and grammatical structure are very different from English. And English is often a second language for many culturally deaf individuals, just as it is for people coming from different or foreign countries. So writing could also be labor intensive for many deaf people as well as healthcare providers. And writing may be found to be cumbersome and inefficient in a medical setting, especially when trying to convey complex and important medical information. And I have seen cases where even personally I've had individuals try writing back and forth to me and cutting out much of the communication that should be given to me and trying to abbreviate, which is not effective. So other considerations in this area is providing visual medical aids. Again, as I mentioned, charts and diagrams, anything to help in explain certain concepts in basic anatomy, for example. Next slide. So for those who are culturally deaf quite often individuals who are deaf and use sign language, especially American Sign Language, the most effective auxiliary aid or service with a medical office which a medical office can provide is a qualified sign language interpreter, and preferably those who are trained in medical terminology. Now, questions some people often have are, do all individuals who are deaf or hard of hearing require or use the same kind of interpreter? And the answer is no. So always be prepared to provide potentially different kinds of sign language interpreters. The healthcare provider should ascertain the particular language needs of the deaf or hard of hearing patient before hiring an interpreter. Some individuals may require interpreters who are fluent in ASL, American Sign Language. Others may require interpreters who use signed exact English, or C-sign, which is abbreviated. Still, there could be others who do not know any sign language and may require oral interpreters who take special care to articulate words for deaf or hard of hearing individuals. And there are people who are trained to kind of help facilitate communication in that method as well. Next slide. This is just an image I just wanted to show of a woman who is laying down or partially propped upright in a hospital bed. She's communicating through a sign language interpreter to a healthcare provider. And she has a look of concern on her face and is obviously, I think, talking about a healthcare condition. Now, I want you to imagine taking out the American Sign Language interpreter in this situation and imagine how frightening and scary this experience can be for this woman to try to explain, whether expressively or receptively, what is happening to herself. So imagine she's trying to explain some heart complications without an interpreter. It can be very frightening and a scary experience. So for somebody to be in an anxious state of mind like that, trying to even partially lip read or even reading and writing back and forth could be problematic. Next slide, please. Here's a common scenario, and this is an actual situation as well, based on some stories we received up here in the Pacific Northwest as part of the Medical Interpreting Task Force. In this situation, a deaf patient ended up in hospital after a heart attack attributed to medical error. And this was because medication was prescribed without the benefit of a sign language interpreter. So obviously this gentleman misheard and misunderstood information and did not take his medication in the way he should have. And there were some unfortunate consequences related to safety. And fortunately, he did survive and recovered. But it was something to think about as far as how providing auxiliary aids and services also enhances and almost assures patient safety. Next slide, please. So as part of the 2008 Amendments Act, the ADA revised the definition of a sign language interpreter, a qualified sign language interpreter, and it's defined as an interpreter who, via a video remote interpreting service such as VRI, or an on-site appearance, is able to interpret effectively, accurately, and impartially, both receptively and expressively, using any necessary specialized vocabulary. And this includes sign language interpreters, oral transliterators, and cued language transliterators, just to name, again, more kinds of sign language interpreters that are available out there. Now, interpreters providing services in the medical setting may need to be able to interpret medical terminology. So now, one thing I want to point out here is the ADA definition does not require certification, although some state and local laws do mandate that interpreters be qualified to provide medical interpreting services. And there are some up and coming new state laws surrounding ensuring they have certification in medical terminology as well. Next slide, please. Here are some other scenarios that happen far too often and are unfortunate in many situations. Some healthcare providers may ask sick children to interpret for their deaf parents. In another situation, There's a case when healthcare providers pressured a deaf man to lip read and interpret for his deaf-blind wife. And this is one I hear often from my friends in the deaf community. Quite often requests for sign language interpreters are often ignored, and they show up in an appointment and there are attempts to write back and forth on paper during the course of a complex and important medical procedure or checkup. Next slide. And one thing the Department of Justice and the ADA makes very clear is that family members should never be used as interpreters. Family members do not meet the requirements of a qualified interpreter because they usually cannot remain impartial and often do not have the language skills or training to effectively and accurately interpret a medical appointment. And if I can elaborate a bit further on this, family members and friends, if you think about it, are also often often too emotionally or personally involved and may have interests that conflict with the patients. They may cause role confusion and are unable to interpret effectively and accurately. Also, family members being used as interpreters or friends can cause problems in maintaining patient confidentiality as well. Now, family members may be used in an emergency involving imminent threat to the safety or welfare of the individual or public, and no interpreter is available, or where specific request by person with a disability, the accompanying adult agrees, and the reliance on that person is appropriate under the circumstances. So again, emphasizing what is a circumstance. So obviously, imminent threat to patient safety and all that makes sense. But for even general procedures or general office check-ins and visits, using a qualified sign language interpreter is often the best way to go. The ADA also prohibits the use of minor children as interpreters, with again the exception of emergencies and situations where the safety of others are at risk. But again, please use caution when I say this, because again, the general rule is do not use family members or children, especially to facilitate communication. Next slide, please. This is something I've just briefly covered already. Again, for a qualified sign language interpreter in medical settings, the recommendation is that interpreters working in settings should have some form of national certification in addition to medical interpreter training, because such certification and training serves as an indication of competence. And again, this goes back to ensuring patient safety in all methods of communication. Next slide, please. Just to review some simple auxiliary aids and services when it comes to communication. If you think about simple situations, which include brief or simple face-to-face exchanges, sometimes very basic aids are usually appropriate and effective. For example, exchanging written notes may be effective when when a deaf person asks for a copy of a form to fill out, or using a smartphone to write and exchange messages. This can be usually accomplished maybe perhaps at a pharmacy where a deaf individual is just picking up medication and a prescription and may be able to get by with just writing back and forth on paper, as long as hopefully that healthcare provider beforehand has provided instructions in alternative format, whether it's a sign language interpreter, to ensure that they know exactly how to use that medication. Next slide, please. So for more complex situations, again, this is where lengthy exchanges of information, this is where we'll be using sign language interpreters or communication access real-time translation, or CART. And this can be, for example, in interviews, counseling sessions, community health events and meetings. Think about also opportunities to provide written transcripts or closed captions on video for pre-scripted situations such as speeches and presentations that you may or may not find in programs that may be offered by healthcare providers, such as nutrition programs and things like that are open to the public. Next slide, please. Now, this is, we're stepping into sort of an area that has received sort of a lot of attention lately, and it has to do with video remote interpreting, or VRI. And there was a new definition provided by the ADA Amendments Act in 2008. And it's becoming more popular in the healthcare provider area, but it does come controversy and limitations, which I'll address here. But the definition is VRI is an interpreting service that uses video conferencing technology over dedicated lines or wireless technology, offering high-speed, wide bandwidth video connection that delivers high quality video images. Next slide, please. Now, there's two images here, basically some people who are receiving healthcare services, and in these two situations, they are sitting upright and probably having either a general checkup or general conversation with their healthcare provider. And the image shows the use of video remote interpreting. If you see on the monitor screens, there is a interpreter provided and working alongside with the deaf patient and the healthcare provider, and even sometimes a family member. So what is important to remember, though, is that the ADA Amendments Act requires specific technology requirements in order to provide effective VRI services. Next slide. And these requirements include specific performance standards, ensuring there's a high quality video and audio. There's a dedicated high-speed connection, and that means usually a direct connect through the internet system, and not relying on Wi-Fi as we know it by connecting through the air, if I can say that. The picture must be clear, large, and sharply delineated, and there must be a good view of the interpreter's heads, arms, and fingers. And voices must be clear and easily understood both ways. And of course, which is one of the most important things, making sure that healthcare staff know not only where to find the equipment, but how they can quickly set it up and know how to turn it on and know how to connect with a sign language interpreting agency in making it work. And this should include regular and ongoing staff training on how to use this equipment and making sure it's working and functioning appropriately. So consider this especially in areas that may have high turnover of staff, ensuring that incoming staff know how to use VRI equipment. Next slide. So this is where we find a lot of controversy surrounding VRI. Some problems that we often encounter with video remote interpreting include a patient being prone. There's actually one story of a patient who had neck surgery, was prone, and was forced to use VRI as part of communication, and in doing so, in the process of turning his head to look at the screen, actually detach the stitches and staples that were in his neck from the surgery. So again, consider the sort of the nature and the context and the environment and whether VRI is appropriate. Often as well as patient is in pain or under stress, under the influence of substances, such as coming out of anesthesia and medications that may impair the ability to focus on a screen. And also some issues include the size and distance of the device, such as people can't see it well, especially here in the Pacific Northwest, we have a large deaf-blind population, people who are deaf and have limited vision, and looking at these small screens is not going to be an effective way of communication. Next slide. Additional problems with VRI include, like I mentioned, the patient has visual limitations as well. Quite often in recovery rooms, there's a bunch of other equipment that may be blocking the visual sight lines to the VRI monitor. There's insufficient signal strength or weak audio. And again, this goes back to relying on Wi-Fi rather than a direct connection to the internet. And quite often, as we see in deaf culture, quite often you'll have multiple deaf family members involved hanging out in the recovery room and being a part of the process of providing healthcare. And not everybody can see the screen at the same time, nor be seen by the camera, so the interpreter can provide effective communication. Quite often the interpreters cannot see the context, identify who is entering and leaving the room, who is talking, and what they are doing. And again, going back to the other issue, as I mentioned before, staff often lack training on how to use the device. Next slide. So the question is, when is VRI effective? So when the patient is feeling able to sit up and to concentrate for non-serious visits to the ER, or as the patient is getting ready to be discharged, this may be appropriate to use VRI. Again, considering the context and the situation and the cognitive capabilities of the patient and the clear understanding, VRI can be effective in some situations. Next slide, please. So when is VRI most effective? The most effective communication for emergencies and urgent care is a combination of an on-call interpreter and VRI. So a procedure of asking the deaf, hard of hearing patient or deafblind patient their most effective means of communication, what is their preference? And I can guarantee you most people in the deaf community will require or want a in-person interpreter. And I do understand that sometimes this can be limited by location in the ruralness of an area and where a live person interpreter may not be available. So, and also if requesting a live in-person interpreter, calling on the, first of all, securing VRI and then calling for a live interpreter to start communication at least. So the idea is if you have reliable and functioning VRI equipment and it's an appropriate situation, it's okay to start using VRI while somebody is sort of in the background calling the local interpreting agency to ensure, hopefully, secure a live in-person interpreter to come over and take over. So usually the healthcare provider can make the call on what's going to be effective as long as it's equally effective, again, given the situation and the nature of the environment, as I've given you several examples. So I have seen some hospitals asking me if it's okay to have a VRI only policy. And my answer is always a resounding no. So entities that rely solely on VRI services are at risk of not providing effective communication. Because like I mentioned, if the equipment or internet connection fails, or the staff doesn't know where to find the equipment or use it, or the situation is not appropriate for the use of VRI, the entity has not adequately provided access. And this has been well documented in several court cases in the settlement agreements. Next step, next slide. So when choosing an appropriate VRI provider, one thing to think about, this is something important, is I've seen many facilities have foreign language services agencies also providing sign language interpreters. So many healthcare facilities have arrangements with remote language translation companies to provide translation for patients who speak other languages. And some companies add on ASL interpreting as one of their options. I do want to bring this up because this is something that you should be aware of and be cautious about, because the question you still have to ask is, are these sign language interpreters qualified? Quite often, people who run foreign language agencies do not have the knowledge and expertise to understand what a qualified sign language interpreter is or who. And so the question is, are they providing, do they think they're providing an actual accommodation, auxiliary aid or service, or are they providing a language translation service? So again, to ask yourself, if you're using a foreign language company that provides translation services, and they say they do provide sign language, find out more in detail and ask probing questions about the nature and the qualifications of those sign language interpreters. Next slide. Now, shifting from sign language to communication access real-time translation, again, we abbreviate this as CART. And this is for individuals, and again, this is a definition that was redefined in the 2008 Amendments Act to the ADA. So CART is for individuals who are deaf but do not rely on sign language for communication and have good levels of reading comprehension. The appropriate auxiliary aid or service is usually the use of transcription services such as communication access real-time translation. Next slide. So the question is, will you be seeing and using CART in all healthcare services? Probably not, but always be prepared to think about situations where CART may be effective. I've got two images on this slide. There's an image of an individual receiving captioning services at a table surrounded by other individuals. And to the bottom right of that image is the CART provider using a stenograph machine to provide captions. And then the other image in the lower right is of somebody providing captioning or CART services to a larger audience that may include more than one individual. So let's imagine for the sake of this presentation, the upper left picture, it could be somebody meeting with a surgical team or a recovery team or whatnot. And this could be an older American who is losing a lot of hearing due to hearing loss. You want to be sure that they have effective communication. Because I can tell you right now, I know so many older Americans with hearing loss who will nod their heads and pretend to understand when in fact they have not. So try using some of those probing questions again, whether somebody wants to use some kind of accommodations, or they may actually request the use of CART in a situation like this, or especially with healthcare programs in which large audiences are involved and people are invited to hear, for example, nutrition improvement programs for aging Americans. In this case, you might get several individuals who request either FM systems, listening systems, or may require CART. And my philosophy is if you can, if you're a large enough healthcare provider and you're providing healthcare programs to audiences, especially large audiences that will or may include our aging baby boomers, please consider using CART as a sort of a courtesy, because quite often those audience members will benefit from it and quite often won't even know that it existed. And it goes a long way in ensuring effective communication and active participation by those in the audience. Next slide. So now we're sort of shifting gears into, sometimes we get questions on our technical assistance line about costs involved and things like that. The ADA talks about undue burden and fundamental alteration. And what this means is the ADA does not require the provision of an auxiliary aid or service that would result in an undue burden or in a fundamental alteration in the nature of the goods or services provided by a healthcare provider. Now, if I can further explain that, a fundamental alteration is a change that is so significant that it alters the essential nature of the goods, services, facilities, privileges, advantages, or accommodations offered by a business. Now, in healthcare settlements from the DOJ, the Department of Justice has indicated that very rarely will this be a legitimate defense for failing to provide effective communication in healthcare settings. So just be aware that a fundamental alteration is often a hard argument, especially with large healthcare facilities. However, next slide, please. We often hear more about undue hardship and the financial burdens of providing auxiliary aids and services, specifically to when it comes to American Sign Language interpreters or real-time translation CART providers. And what the ADA says is that for undue burden and fundamental alteration, an individualized assessment is required to determine whether a particular auxiliary aid or service would be an undue burden. Next slide. So this slide, this is what we get often calls to our technical assistance line. A small healthcare provider, for example, complaining that it costs too much. And in a court of law, and the DOJ, what they'll say is a healthcare provider is expected to treat the cost of providing auxiliary aids and services as part of the overhead cost of operating a business, as long as the provision of that aid or service does not impose an undue burden on the provider's business. The provider is obligated to pay for that auxiliary aid or service. So, for example, a payment may be considered an undue burden or a fundamental alteration if it would cause your doctor to go bankrupt or out of business. So it's going to be hard to find such a situation where providing a sign language interpreter for one appointment would cause and wreak havoc on the business and put them in dire financial straits. Now, a loss on a single appointment or even providing ongoing care for a patient does not establish an undue burden or fundamental alteration. The overall financial circumstances of the doctor's practice or office must be considered. So in many settlement agreements through the DOJ, especially through the barrier-free healthcare initiative list that I mentioned at the beginning of the presentation, settlement agreements negotiated with the Department of Justice are clear. Being reimbursed less than the cost of services for a sign language interpreter is not considered an undue burden. A healthcare provider cannot charge a patient either for the cost of providing auxiliary aids and services. So this goes back again to, like I mentioned, we get calls from doctors saying, I can't afford this, it's expensive. I just can't afford it. And I say our response typically is, in a court of law, you will need to be prepared to show on paper that providing such that one service or multiple services would basically put you in the red or put you into bankruptcy. And that would be including looking at all potential parent organizations that involve that clinic, and any connections to the financial resources and financial assets to make such a decision. Next slide, please. Continuing with the undue burden and fundamental alteration, when an undue burden can be shown, for example, the healthcare provider still has the duty to furnish an alternative auxiliary aid or service that would not result in an undue burden and to the maximum extent possible would ensure effective communication. So, but again, this goes back to first demonstrating that the provision of a preferred choice would definitely and actually be an undue burden. Now, I just want to mention covered entities may require reasonable advance notice from people requesting aids or services, especially sign language interpreters, based on the length of time needed to acquire the aid or service. So sometimes we see policies, please request an interpreter 2 weeks in advance or 9 days in advance. However, you may not impose excessive advance notice requirements. So even with walk-in requests for aids and services must be honored to the extent possible. So whether or not you can find a sign language interpreter on the same day of a same-day request, the least you can do is offer alternatives. And if the alternatives are not agreeable, then certainly request an appointment as soon as possible when in fact you can arrange for a sign language interpreter or VRI as an example. Next slide, please. So as we get to wrapping this up, I do have a few slides addressing how to best go about in developing a good policies and procedures to ensure that the provision of auxiliary aids and services for people with communication disabilities are best maximized and ensured and if not guaranteed. So healthcare providers are encouraged to enact internal policies and procedures that address the specific communication needs of the entity and the patrons they serve. So drafting policies and providing training on the protocols for arranging auxiliary aids and services keeps staff members informed with how to comply with the ADA. Next slide, please. When it comes to establishing an effective communication office policy, frontline staff should ask deaf patients, for example, what their preferred communication needs are, and document that in the patient's medical records, so it's always there for repeat appointments and things like that. And build a database of qualified sign language interpreters and referral agencies with expertise in medical settings. So, sort of in a nutshell, documentation in the chart file should be clear on how any language or communication needs will be addressed or were addressed with the patient at each visit. And this will also include any reason why accommodations were declined by the patient. So it can be made clear, for example, that specific auxiliary aids or services may not work for that individual. Now that database I mentioned should be used as a reference for all medical situations that may come up in the future. Medical centers, for example, including healthcare providers, can contact various organizations to learn about potential listings of certified sign language interpreters. Quite often the Deaf and Hard of Hearing State Commission, many states do have a commission or an office for deaf and hard of hearing services, and they are often a good connection to connect with and find out various lists of agencies and freelance interpreters available in the area or state that may be available to provide services. And quite often they'll link, there's also regional links for regional offices for the registry of interpreters for the deaf, RID for short. And there are good resources as well to go to find qualified sign language interpreters in the area. Next slide. Just continuing, an effective communication policy will also include a definition of who is entitled to auxiliary aids and services. And again, this is not only people who require them because of a disability, but also family members, spouses, partners, who may have a legitimate right to be involved in that healthcare service. Several examples, or various examples, of, if not all, of auxiliary aids and services that the entity has available, processes on how to respond to requests for an auxiliary aid, and how long it should take to respond to those requests. So this is very critical because once the healthcare provider has been put on alert to obtain a sign language interpreter for an appointment in 2 weeks, for example, there should be a process in place to ensure that that's being acted upon in a quick and expedient manner from the point that's been requested. Quite too often, unfortunately, I've seen situations where an interpreter has been requested and it was not followed upon until the day of or the day before an appointment. And at that time, it's too late to find an available provider for sign language. Next slide, please. This also includes, as far as developing policy, including where devices are stored. You won't believe how many times I've worked with healthcare providers, especially hospitals, and ask about their VRI equipment, and the response is, I'm not sure where it is.
Michael, 1 second here. The captioner was lost, so let's give him a moment to reconnect.
Sure.
Sorry, everyone. We'll get back to this as soon as the captioner reconnects.
Can you hear me now, Lewis?
We can hear you. Just waiting for the captioner to reconnect. There we go. Hey, hold on. Okay, we see him. All right, Tony, we are going to reconnect you in. Aha, and I see it on the stream text. And so this gives me an opportunity to tell everyone, if you are not liking the captions on this system, you can go to the stream text link that we put in there earlier, and it's coming up on that as well, and it may be preferable. Okay, Michael, sorry, go ahead.
No worries, just doing a quick test. Can you hear me okay?
Yep, you're doing fine.
Great, okay. I believe I left off on continued discussion on developing an effective communication policy within the healthcare setting. And I was mentioning making sure that you know where devices such as BRI equipment is stored, the names of subcontractors that provide auxiliary services such as interpreters, captioning of CART, and brailing services, for example. Hours of when subcontractors are available to provide services, and also procedures for obtaining a qualified interpreter for last minute or during an emergency. And this, in my experience of working with hospitals that have a good policy in place, they not only have lists of various agencies and freelance interpreters available, but they also have interpreters who have agreed to be on call 24 hours a day, 7 days a week for some of those unique emergency visits that could happen at 2 or 3 in the morning. Next slide. And again, developing effective communication policy also includes the definition of who is entitled to aids and services. Examples, I'm not sure I said this one already, how to respond to a request for auxiliary aids such as interpreters, and again, how long it should take to respond to request. I believe that's a repeat slide. Next slide, this. And then I should go back one slide, I'm sorry. And one more forward. There we go. The effective communication policy should also identify when it's appropriate to exchange written notes and when an interpreter should be called, who is considered a qualified interpreter, have some language in there in the policy about friends, family, and children, and impartial parties being unqualified to interpret, and appropriate and inappropriate times and settings to use video remote interpreting, VRI. Next slide. Some resources to think about and have at your disposal, including the ada.gov website, which has regulations and standards all about the ADA and effective communication. And of course, don't forget about your local ADA regional center as part of our national network of ADA centers. They have a 1-800 number, 1-800-949-4232. We all share that same number, so people can call us for confidential technical assistance on rights and responsibilities for not only effective communication, but anything that has to do with access and inclusion. The U.S. Access Board, and there's a website there, www.access-board.gov, is also a good resource to look about not only physical requirements for accessible healthcare facilities, but also effective communication requirements. Next slide. And especially because the use of sign language interpreters can often be a confusing and complex situation for many people new to the field. These are some good resources to go to as well. And that includes the National Association of the Deaf, which will often have connections to your local resources for sign language interpreters. The National Federation of the Blind would also be a good resource to go to find out local resources for brailing, for example, or getting some ideas on how to provide alternative formats to print. And the Registry of Interpreters for the Deaf, as I mentioned earlier, RID, is also a good resource to connect about learning about your local resources for qualified sign language interpreters. And not only that, but also those who may be certified as well in medical terminology. Next slide. And think about some of your local common state resources that are often common in most states, such as your disability related agencies. This can include the local centers for independent living or your state independent living council, also the state office of deaf and hard of hearing services, the Department of Services for the Blind, as I mentioned before, and also getting to know your interpreter referral agencies. Next slide. So the next two slides I'm not going to go through, but these are just various sources that I sourced for this presentation. And we'll go to that very last slide, Lewis. And I just do want to say, I hope I gave you some good information to start with. And as I mentioned before, we are here as the ADA National Network to provide support and resources to you should you have any questions. Don't be afraid to give us a call, reach out to us by email, and go to our websites, whether it's regionally or the national website at adata.org. At this point, I'm going to turn it over to Lewis, and I'm happy to go through and answer any questions.
Thank you so much, Michael. That was great. And everyone, please, I want to remind you you can submit your questions in the chat window. You choose that down there at the bottom of the screen, or you can hit your Alt key to bring it up and hit it again to make it stay. All right, we have quite a few questions here, Michael. So the first question has to do with a medical office that is leasing space at a hospital and is not affiliated with that main hospital. And the person says that the hospital claimed that they are not responsible for the provision of accommodation for the office. And the medical office as a tenant, what if they decline to provide the accommodations? So it's like an issue of who's responsible.
Okay, so if I understood the question right, it's basically a sort of a private business of sorts in Baldwin Healthcare, associated and affiliated with the hospital space. And the question is, who is responsible? Is that right?
Right.
Yeah. Well, typically it's going to be the private provider of the services is responsible. However, quite often in many settlement cases, as we've seen, is that even the overarching entity that owns the property has some responsibility as well, especially if it's a state-run university hospital, because their responsibility as well is if they're renting out space to a provider of services and the provider of goods, then they have to ensure that they are being accessible as well. So in that situation, especially if it's affiliated with a state hospital, if I'm correct, it may be up to a point of negotiating costs involved in providing an auxiliary aid of service, but it still does not relieve that small private business of their obligation to provide effective communication and any appropriate auxiliary aid or service.
Okay, great. The next question is, what can a deaf person do if the provider refuses to provide an in-person interpreter, but instead wants to use VRI or wants to pass notes?
That's a good question. Now, what I hear a lot sometimes in the deaf community is many individuals feel they have a right to a live in-person interpreter versus VRI. The reality is, if the entity is providing the VRI service in the appropriate circumstances, and it is available and it is working well and effective, and they are doing their due diligence in providing the appropriate interpreting services, even though it may not be the preferred mode of the requester. Now, if the requester is requesting a sign language interpreter for a lengthy and complex situation, and VRI is being attempted to be provided and it's not working well, that is ineffective communication. And usually I encourage the deaf individual to either reach directly to, if there is an ADA coordinator within that system, to go through that channel first to see, to resolve that issue. Otherwise, ultimately, filing a complaint with either a state Human Rights Commission or going to the Department of Justice and filing a complaint that way. I hope that I got that right.
Okay, great. The next question is, what are your suggestions for Medicaid limitations with billing for extra time needed at times of providing accommodations? So many times providers state that the extra time is not billable. These policies are not typically driven by a provider, but instead by insurance, including Medicaid.
That's a good question. That's sort of a topic I'm not fully versed in just because it has to do with internal Medicaid, Medicare policies surrounding time. What I do know is that, again, policies and procedures should be flexible to ensure effective communication. I do know, for instance, that some Medicaid, Medicare situations do possibly, I think, cover some of the costs of sign language interpreting. But that is not my area of expertise at the moment. I would be happy to do that research and get back to that person who posed the question, or get back to this group if you take down my email, yeah, which is MIKE67 at uw.edu. I'm sure you can find my contact information anyways. I'd be happy to do some research and see if I can find more specifics around that question.
And Michael, if you have an answer you want to write up, if you do find something, you can send it to us, and we'll post it with the webinar archive on this, so people can
Perfect.
come back and look at that later if they want. All right, the next question is, many doctors' offices are now requesting that people complete forms online before arriving at an appointment. This allows a person to complete the paperwork at a time that is convenient for the patient. Sometimes these portals are not accessible to a screen reader user. While having a reader on site might provide access, that doesn't that change the nature of the experience in a way that is not equivalent to non-disabled people?
It's a very good point too. Yeah. And it's easy for somebody to assume, well, if you can go into the office and fill out a form, then you can get around that issue with the website inaccessibility. But the reality is, and part of the work we do is to ensure and promote that everybody has the same and equal opportunity to complete paperwork in the manner that everybody else has an opportunity to do. So point being is that healthcare provider must think about having an accessible website and process online to ensure that people have the same opportunity as anybody else. And this is important to think about because we are seeing more and more settlement cases and court cases coming out now with individuals, especially those with vision loss, have filed complaints against inaccessible websites. Now, there's nothing right now in the ADA that says a Title III or private entity website must be fully accessible, but the reality is court cases are setting precedent and ruling in favor of the people filing the complaint. So a very good question. And so the point is, think hard and be sure you are providing services, even through the website, in an accessible format that's usable by all.
Okay. And the next question, excuse me. Do you have anything that states that communication boards for charts diagrams are allowed in healthcare settings?
Say it once more.
Yeah, do you have anything that states that communication boards for charts diagrams are allowed in healthcare settings?
That's a very good question. Usually, as part of the ADA National Network, we usually refrain from recommending specific vendors who sell such equipment. What I can offer as far as advice is, if you look up, on the internet and by Googling, for example, accessible, charts, medical charts for people with disabilities, you might find some resources there. I don't think there should be any limitations as to what somebody can use as far as providing visuals when it comes to ensuring effective communication. Of course, some may be more effective for others, depending on the quality and the nature of the graphs and the charts and the pictures and diagrams, whatever you're using. But there should be, again, if it's from policies, procedures around using additional equipment or diagrams, thinking about modifying those policies to allow for communication. I guess one other recommendation is to check in with your state or local office for developmental disabilities for ideas and resources on where communication tools can be obtained for the purposes of effective communication in healthcare.
Okay. And another question, do you have an available a sample policy that addresses service aids such as amplified phones, etc.?
I'm just reading the caption for a second.
Mm-hmm.
So basically an example policy of providing either sign language interpreting or other auxiliary aids or services, is that right?
Correct.
I probably do have some somewhere. I'm going to make a note to myself to share with Lewis, to share with the group as part of the archive webinar. Again, I'm going to be very cautious about that because not all developed policies and procedures are going to be pertinent to your facility or office. But I can probably look up some good examples of some healthcare providers that Lewis and I know of that can be proactive in addressing effective communication and see what we can put together, and we'll share with the group.
Right. Okay, great. Do you suggest having consents in larger print at a minimum, specifically for registration and or procedures?
Certainly, I'm always a proponent of having a set of materials in large font print. Sometimes it's just as easy as if you have a Xerox machine within the office to just basically use legal paper and larger size, or going back to the document version and large font and printing something out on the spot. So it definitely is always being proactive to have some stuff available in a large font. And it's a great idea, though. I'm all for it.
Okay, there was a person earlier who asked if there's a recommended list of cart vendors in Washington State, and I think you listed some resources for that person, and also noted that, you know, we don't really make recommendations on that, but if the person in Washington State wants to call the 800 number, they can, you'll get the Michael's TAs, and they can talk to you a little bit more specifically about that. So we're going to move on to the next question. Person says, I noticed that the term Medical Interpreting Task Force regarding VRI, who are they and what do they do?
Very good question. Basically, the Medical Interpreting Task Force was a group of qualified sign language interpreters and consumers and members of the deaf community in Washington State that got together about 4 or 5 years ago to actually address this very topic of the ineffective procedures and policies and practices that many people are experiencing in the healthcare industry of not receiving good quality interpreting services. It was sort of a series of community forums in working with state legislators to try to promote state requirements for medical certification in sign language interpreting. And so it's sort of like an advocacy group that went about to develop some common best practices to ensure effective communication, especially with those who are culturally deaf and using sign language interpreting. I'm not quite sure about the status of the group at the moment and whether they have additional materials to share. This is where we received some of the common scenarios and if not, if I can say the horror stories of being denied access in healthcare settings.
All right, well, everyone, it is pretty much at the top of the hour, and I want to respect everyone's time that you committed to this. We realize that many of you still have questions, and there are a few that are still backed up here, and apologize if you did not get the chance to ask your question. But you can call your regional ADA center at 1-800-949-4232 and ask that question. Most of these questions are ones that the TAs at our regional centers will be able to answer for you. Um, do want to tell you that you'll receive an email with a link to an online session evaluation. Please complete that evaluation for today's program. We value your input and want to demonstrate to our funder the importance of this effort. We want to thank Michael today for sharing his time and knowledge with us. It was a great presentation. And a reminder to all of you that the session was recorded and will be available for viewing next week at adapresentations.org in the archive section in the health area. So thank you very much for your attendance today. Next month, we will we'll announce the next webinar via the email, and you will be able to register for that 2 weeks ahead of time. So thank you for attending today's session. Thank you again, Michael. And for everyone, have a good rest of your day. Bye-bye.
Bye-bye. My pleasure.